Welcome to GMCS Masterclass, Medical Cannabis Essentials with Dr. Bid. Hosted by Dr. Hemant Bid, Program Director at Morehouse School of Medicine and GMCS Educational Partner. An educational series exploring the science, research and applications of medical cannabis. Dive deep into the latest developments in medical cannabis, patient care and clinical research. Brought to you by the Georgia Medical Cannabis Society, committed to advancing knowledge and improving patient outcomes. Stay tuned for the GMCS Masterclass, Medical Cannabis Essentials with Dr. Bid.
Good evening, everyone. Good evening, and welcome to today's second episode of the Medical Cannabis Essential by Dr. Bid. And I will be your host, and I will coordinate that today's very wonderful and interesting session where we are going to discuss pharmacology of medical cannabis, which is a very interesting topic. So, first of all, I would welcome you all, and thanks for joining us today. And we have a special guest today, and who is going to give us her experience of medical cannabis with related to the pharmacology of cannabis, and which is a really, really interesting topic because medical cannabis has been approved in more than 38 states in the United States. And we are taking it in a different level where we are going to discuss a lot of clinical outcomes as well as the clinical trials, pharmacology of medical cannabis in our shows. And currently, I serve as a program director for Medical Cannabis Master's Program at Morehouse School of Medicine. So I welcome you all for today's show. Thanks for joining us. And let's welcome and give a warm welcome to our guest, Anita Rasoda. And Anita, being a very good friend of mine from a couple of years now. And welcome, Anita, for the show today. And thanks for joining us today. So a little bit about Anita, that she is a medical professional with 15 plus years of experience in pharmaceutical care, patient program development, medical business consulting, medication therapy and management, and clinical transformation. Anita has a proven track record leading multiple complex healthcare related projects while managing a heavy clinical load and mentoring and supporting pharmacy students to become medical leaders for tomorrow. And she been involved in the medical cannabis field actively from last couple of years, and she been a very good one of the instructors in our summer bridge program also. So thanks for always being a support and sharing your knowledge to the students, Anita. And it being a pleasure to welcome you today for the GMCS Masters class to discuss about the one of the critical and important topic of medical cannabis, which is the pharmacology of cannabis. As you know that, like when there are every day the research globally which is happening, and there are so much new products are coming that and there are so many factors that which plays very important role that how medical cannabis is going to affect, or we are going to get the medical benefit for so many different disease subset. And one of the biggest factor and one of the major factor is pharmacology. And pharmacology is a branch that where we study the pharmacokinetics and pharmacodynamics. So I know that you're going to talk about that, and which is really, really important, that how we see the bioavailability of the drug, the first pass effect, etc., with various different compositions and various different the manufacturing as well as the new products are coming in the market. And there's no doubt that there are new products are required in the market. The reason being is because medical cannabis is a personalized therapy. And as we know that, every human being is different. Their metabolic rate is different. Their age is different. Their genetics is different. So medical cannabis itself, that, like every patient responding in a different, and every patient has a different limitations, that which actually creates a lot of barrier for the clinicians like you to treat the patients. So that means that definitely that we need a lot of products and various different kind of products, including that either it is patches or suppositories and edibles and so on, because it is a very valuable drug that which is helping a lot of patients throughout the globally actually, and in so many disease subsets. And we both know that, like it being going on and so long, and there are latest development and research every day coming with respect to either it is endocannabinoid system or either new development related to the pharmacology of clinical trials. So we are very excited to hear about your thoughts and your studies, as well as that your patient experience related to pharmacology of cannabis. So again, welcome to GMCS Masterclass. Floor is all yours.
Thanks, Dr. Bid. What a great introduction. I think it's a great segue into my presentation. So I'll jump right in, and then at the end, we can just go into an open discussion Q&A, and I'll try my best to answer and share some of my experiences along the way. Okay. All right, so I got a little brief introduction, and then we'll go into some dosing strategies, my favorite drug interactions, what we look for when monitoring patients, two important things to talk about: withdrawal and dependence, and then counseling pounds. Irrespective of what type of professional you are, if you're working in the cannabis space with patients, we need to be counseling them. We need to be ensuring that it's a collaborative approach to care, and we take a harms reduction approach, knowing that patients are using this, and us as caregivers and support systems, we're there to enable patients to make an informed decision about their therapeutic options. All right, so I'm going to briefly touch base about the cannabis plant and how it differs from pharmaceuticals, and then we'll jump right into the various cannabinoids, the endocannabinoid system, and yeah, we'll take it from there. So when we think about traditional pharmaceutical, Western medicine, and cannabis plant-based medicine, it's very different. We have to change our mindset of how we view the two. There's several reasons for that, but I'll like to highlight some of the different reasons. First being the complexity of cannabis versus a single molecule drug or an active pharmaceutical ingredient, which we use in Western science. It's hard for standardization and consistency. The mechanism of action of how cannabis works within our body. And we also have like regulatory and research challenges. And then now we really lean on real world evidence and patient experience. So we're moving away from traditional models of research, and we're really looking towards patient experience and real world evidence and AI and machine learning as to how we tailor evidence-based medicine in the cannabinoid therapy world. Oops. All right, so complexity of cannabis versus single molecule drugs. When we think about traditional pharmaceuticals, these typically involve a single active pharmaceutical ingredient that is isolated, purified, and studied in controlled clinical trials. The effects of the drug can be directly attributed to that single molecule. Whereas when we look at cannabinoid therapy, cannabis contains a multitude of compounds, including cannabinoids like THC and CBD, terpenes, and flavonoids. The therapeutic effects are often due to what we call the entourage effect, where these compounds work together synergistically. Isolating a single cannabinoid may not replicate the full therapeutic potential of the whole plant. So just to kind of go further, so entourage effect, what is it? So this is a theory that the full spectrum of the cannabis plant or other plants work best together. We'll also see this type of terminology, entourage effect, when we look at mushrooms or psilocybin type therapy. So really, this is when we look at what the plant works best together. So the interaction between all the compounds from the plant, such as phytocannabinoids and terpenes, come together to enhance their effect. Most prescription drugs are based on that single molecule that I talked about, the API. There are even two FDA-approved drugs based on the two main molecules in cannabis, the cannabinoid THC and CBD. However, cannabis is a plant, and want to reiterate, it contains hundreds of different compounds. Back in 1999, two researchers, uh, uh, Simon Ben Shabat and Raphael Michelon, they first mentioned that as a plant, cannabis may be superior to some pharmaceuticals thanks to the effect of the entourage compounds. This hypothesis was based on their observation when researching the endocannabinoid system. So we knew back then even that there was an entourage effect taking place. And this was before we realized that the cannabis plant had so many different molecules to work off of. Another important barrier or fact that you can't compare pharmaceuticals to cannabinoids is the fact of standardization and consistency. So traditional pharmaceuticals, these are manufactured to be highly consistent in terms of dosage, purity, and potency. There's a standardization that ensures that each dose delivers the same therapeutic effect. In cannabinoid therapy, the composition of cannabis can vary significantly depending on the strain, growing conditions, and extraction methods. This variability makes it challenging to ensure consistent dosing and effects. Hence, why we have authorizations and we don't have drug identification numbers because it's not the same product, it's not identical. Every variation of plants out there will have their own specific formulations. Furthermore, mechanism of action. So, traditional pharmaceuticals, the mechanism of action is usually well understood and targeted. For example, a drug might inhibit a specific enzyme or receptor to produce its therapeutic effect. Whereas in cannabinoid therapy, the mechanism of action for cannabinoids are more complex and involve multiple pathways and receptors in the body, including the endocannabinoid system. This complexity can make it hard to predict and study its effects. And then looking at regulatory and research challenges. Traditional pharmaceuticals, these undergo rigorous clinical trials and regulatory scrutiny to ensure safety and efficacy. The process is well established and standardized. However, in cannabinoid therapy, research on cannabis is often hampered by regulatory restrictions and the plant's legal status in many regions. So, take, for example, the differences in the Canadian landscape and in the American landscape. Canada legalized medical access to cannabis in the early 2000s, and then 2018 we made it accessible recreationally, whereas in the states it's done state by state. So some states have access, whereas some states may not. And so again, there's hope that everybody can standardize its approach to even having it being offered to patients in a similar mechanism throughout the country. Patient experience and real world evidence use. So, traditional pharmaceuticals, these are typically prescribed in a controlled manner with clear guidelines on usage and monitoring. Whereas cannabinoid therapy, patients often use cannabis in a variety of forms. They could be smoking it, edibles, oils, and various of dosages, which can vary widely depending on the indication, the size of a patient, their experience, etc. Real world evidence and patient reported outcomes are crucial for understanding effects in everyday use. So thinking back to the history of cannabis, it's been around for a long time. So I appreciate the North American landscape. We're not new to cannabis. We had a robust cannabis and hemp industry prior to the advent of the pharmaceutical industry. But these are just some pictures to kind of highlight medicines that were available at the turn of the century. And, now that it's made its resurgence, it's hope that we'll be able to take from the past and use real world evidence to move this medicine forward. So endocannabinoid system, to really have a good understanding of how cannabis works in our body, one must have an appreciation of the endocannabinoid system. So the endocannabinoid system is a complex cell signaling system that plays a crucial role in regulating a wide range of physiological processes in the human body. This was discovered in the early 1990s when researchers were exploring how THC, the main psychoactive compound in cannabis, affects the body. Um, the endocannabinoid system has many different components. So we have the endocannabinoids. Um, these are naturally occurring compounds in the body that are similar to cannabinoids found in cannabis. The two primary endocannabinoids found in the human body are AEA and anandamide and 2AG. Um, the other components we have are receptors in the endocannabinoid system. So these are found throughout the body and are involved in various physiological processes. The two main types of receptors are your CB1 receptors, which are primarily located in the central nervous system, the brain and the spinal cord, and then CB2 receptors, which are mainly found in the peripheral nervous system and especially in immune cells. And another component of the endocannabinoid system are enzymes. So these are responsible for breaking down the endocannabinoids once they have carried out their function. So that's just a brief overview. We're not going to go into too much detail so that we can go into some of the more nitty gritty details of the pharmacology of cannabis. So just to review the pharmacology of the cannabis plant itself. So the plant itself contains many active substances, more than 1,200 different, 120 different phytocannabinoids and more than 500 different terpenes. The two main ingredients that we know of so far are THC and CBD, and these are working on on the receptors CB1, CB2. In addition to the THC and CBD cannabinoids, the ones that have now come to limelight are CBN, CBG, and CBC. So THC, has psychoactive effects. THC is the main compound that causes the euphoria, and it gives that high sensation. The interaction with the endocannabinoid system, it primarily binds to the CB1 receptor in the brain, and this helps to affect mood, memory, pain perception, and appetite. So its therapeutic uses include pain management, nausea and vomiting, appetite stimulant, muscle spasticity, and sleep disorders. CBD, it's non-psychoactive, unlike THC. It does not produce a high. Its interaction with the endocannabinoid system is a bit more complex. It doesn't bind directly to the CB1 or CB2 receptor, but influences them indirectly. It can also affect other receptors and ion channels in the body, contributing to its therapeutic effect. So some of its therapeutic uses is an anti-inflammatory, can also be used for anti-anxiety, so mood conditions, and it also has pain relieving properties. Um, a newer cannabinoid that's been making headway is CBN. This one is mildly psychoactive, and it is similar to THC. It forms as THC ages and breaks down. So its interaction with the endocannabinoid system is that it has a weak affinity to a CB1 and CB2 receptors, but it's thought to have potential sedative effects. So it's great for sleep. So as we learn more about the different cannabinoids and as we try to isolate them similar to pharmaceutics, we're going to find certain molecules may have benefit and that we might be able to pair different cannabinoids together depending on what conditions we're using them for. So CBN is a great one to help patients that have difficulty with sleep and need sedation. It's not psychoactive, or it's mildly psychoactive. So people that are worried about that high from THC can try CBN to see if it works for that. Another molecule, CBG, this is also non-psychoactive, and it's considered a non-psychoactive cannabinoid. Its interaction with the ECS is that it's a precursor to other cannabinoids like THC and CBD. It interacts with both CB1 and CB2 receptors. And right now it's being studied for its potential as an anti-inflammatory, and it has neuroprotective effects as well. And another one that we've been seeing more in market lately is CBC. CBC has a non-psychoactive properties as well. It does not produce a high. And it interaction with the ECS, it's believed to bind poorly to CB1, CB2 receptors, but it's thought to interact with other receptors involved in pain perception and inflammation. So we're going to see a lot more of these minor cannabinoids starting to take headway as we find out more of their uses and benefits and how we can kind of pair them with the ones that we already know of. So the cannabinoid and the endocannabinoid system. When cannabinoids, just to reiterate, when cannabinoids from the cannabis plant enter the body, they can either act to activate or inhibit the endocannabinoid receptor. So this is just going back to how medications and drugs work within our body, and this can lead to various effects. So THC, it binds to the CB receptors. This can alter mood, perception, and appetite, as I already mentioned. CBD, same thing. It's going to come into your body. It's going to interact with the endocannabinoid system, and it's going to help to modulate our pain perception, reduce anxiety, and help reduce inflammation without causing that high. And these newer, these minor cannabinoids, CBN, CBG, and CBC that I mentioned, these cannabinoids are being researched for their potential therapeutic benefits, including the pain relief, anti-inflammatory effects, and neuroprotection. So many things to kind of keep our eyes open to as we learn more about these various cannabinoids that this plant has. Here in Canada, we've got a list of potential therapeutic indications which we are already using cannabis for. So this graph here kind of illustrates the different symptoms patients experience, and then on the top here, the different disease states. So, for example, we use it in multiple sclerosis, spasticity being a big one, especially THC, but for pain. People use it for anxiety, for PTSD, irritable bowel. We seem to use it for pain and nausea, neuropathic chronic pain for pain reduction, for anxiety. We can use it to help for mood improvement, sleep, fatigue. So as the research and real world evidence plumps out, we're going to see more and more uses for it as it becomes a tool for deprescribing of other medications. Oftentimes, a patient can replace multiple pharmaceuticals with just the initiation of cannabinoid therapy. So it's a lot of interest, and there's a lot of hope that, by bridging the two together, that we're able to really optimize a patient-centric care and what works best for the patient instead of very general approach to care, what we see with the evolution of the pharmaceutical industry. So with goals of therapy for medical patients, we need to really reiterate like cannabis for medical purposes. Patients are using it for a medical condition to alleviate symptoms. Their goal is to minimize, and our goal as clinicians is to minimize intoxication and harms, and to really maximize the therapeutic effects. Here in Canada, we have 2 points of access. You can access it recreationally, where you can go to a cannabis recreational store, but unfortunately, the people working there aren't able to speak of medical conditions. So we still have a medical route, which is a bit cumbersome. It requires a patient to get an authorization by a healthcare practitioner, and the laws are still that they have to fulfill that through a medical LP, and then it's still drop shipped to the patient. So we still don't have a lot of point of care of access for medical patients. But as the world evolves and access evolves, I think it's going to be a time near in the future where we'll be able to provide patients with medical care, counseling face to face, and not have to work through these tight regulatory bodies that are in place currently. And then moving on to the next slide. When we think of dosing, there's a couple of factors to consider, given the fact that there's no one shoe fits all for patients. So I'm just going to pivot to some dosing strategies and what we look for. Dosing parameters are highly variable due to factors including previous exposure. So patients might be naive or tolerant, but they've already had utilized this before in the past. Genetic variability. This could also deal with absorption metabolism. So pharmacokinetics and dynamics play a role. Route of administration, how a person takes and ingests the cannabis. Smoking and vaporizing will have a quicker onset of action versus if you take something ingested or apply it topically. As well, potency of the strain. Again, because there's no standard dose or standard formulations, we're going to see different variations of potencies and strains and ratios of THC to CBD. So many different variabilities to take into account. With respect to ingested cannabis, the absorption variability can be based also on gastric pH and presence of food. THC delays gastric emptying, so that can prolong the onset of action. Some experts recommend starting cannabis strains with low THC and high CBD. So start low, go slow. And this is to reduce risk of adverse effects and to gradually increase the potency in order to meet the therapeutic needs. So, the lower you start with and the slower you go, the less likely you'll run into adverse events because you'll hopefully be able to optimize the dose that's right for the patient. And so really there's no scientifically defined dose for any medical condition. Dosing is individual and requires a titration approach. Most use an equivalent of 3 grams or less. It really varies anywhere from 1 to 3 grams. Sometimes patients need more, up to 5 grams a day, but it's really individualized. Routes of administration. So inhaling, like I mentioned, has a rapid onset of action, minutes, higher blood levels, and shorter duration of action, about 2 to 4 hours. When you ingest it or apply it topically, so in oils, foods, it's a slower and erratic onset of action, can take anywhere from 30 minutes to an hour, 90 minutes, and it tends to have a longer duration of action. So, a 4 to 12 hours. And oftentimes, if I teach patients that are dealing with chronic pain or have chronic conditions, and they're looking for short acting, long acting, we may rely on a combustible or an inhalant for acute response, and then take an oral or something that's ingested for that long acting. So we kind of mimic what we see in pharmaceutical: immediate release with the inhalation products, and then sustained release with having taken oral product because it'll last longer. And it's recommended to wait a minimum of 2 hours between administration of doses, and this is to prevent overdosing. Not that anyone has ever overdosed and died from a THC, but someone can take too much and have unpleasant side effects. So there's no real standard titration protocol, but there's some suggestions out there, and here's one as an example. So a suggestion is to start with a initial low dose of CBD, like 5 mg, and a low dose of THC, such as 2.5 mg. There's titration protocols in the literature that have a conservative, routine, and rapid protocols. And then really we want to monitor and adjust based on patient experience. So it's really important for regular follow-ups and dose adjustments based on the patient's response. There was a recently studied consensus guidelines, and this study here had 3 different protocols that were developed. So they had a routine protocol, a conservative protocol, and a rapid protocol. And essentially the protocols were starting with varying amounts of CBD and THC and titrating to the patient's response. So a conservative protocol, they started with a dose of 5 mg of CBD once daily, and slowly titrated it up every 2 to 3 days, by 10 up to 10 mg or up to 40 mg a day or so, going through 10 mg intervals. A conservative interval would be appropriate for someone that's frail, elderly, very sensitive to side effects. You'd want to go slow and steady with them. So it's not someone that's urgently wanting to like have a quick response to whatever symptomology we're trying to address, but someone rather who has some time and patience and wants to start this off in a conservative manner to see how they tolerate it. A healthy younger adult, you'd probably want to go with a routine protocol where you start with 5 mg twice a day of CBD, and then again, you can titrate up by 10 mg every 2 to 3 days to a response. And then a rapid response would be for somebody that has acute pain, maybe a cancer patient that and is needing rapid onset of pain relief. And this is where you would start with a balanced product of THC to CBD, 2.5 to 5 mg daily or twice daily, and then titrate by 2.5 to 5 mg every 2 to 3 days as the patient responds. So most of these protocols, again, we're starting with CBD, and then we're going to add on THC as the patient responds. So they suggest to titrate up the CBD to a reasonable dose, and if they're not seeing a good response, to add in THC thereafter. And the reason we do that is because we also know that THC can act in synergy with CBD. So CBD on alone might be quite helpful, but when you add in a little bit THC, it can make it that much more effective. So another way to approach dosing patients is based on their needs. So chronic pain patients, we know from studies that use of CBD predominant and THC predominant products tend to be, what patients need, where there's a balance of both. When it's neuropathic pain, same thing. There's really good efficacy to use THC and CBD in combinations. We have studies to show epilepsy, especially pediatric epilepsy, that CBD's role has been helpful in reducing seizures. Anxiety and depression, so anything that's mood related, we tend to use lower doses of THC and CBD. And I'll talk a little bit further about contraindications, especially in mental health. So just as a reminder that there are certain conditions where medical cannabis may not be appropriate, and so certain psychiatric conditions, THC may be precluded from the regimen, and that's because it can cause psychosis. But that's not to say that we're not studying CBD, and the potential of CBD in these roles is real world evidence is showing us that it can have great effect. And then cancer-related symptoms. So we see patients having great benefit from THC products for nausea and vomiting and appetite stimulation. And again, based on the slow and steady titration protocols and what we're using the plant for, we can really try to tailor it and make it patient-centric based on that patient's needs. This graph here kind of illustrates another, reiteration of start low, go slow. So higher THC product doesn't necessarily mean better pain control, and that's again because of the entourage effect, and we have synergy with the various cannabinoids working together. Health Canada suggests 1 to 3 grams a day. So on average, 2 grams a day would be a pretty reasonable place to start a patient at. And the literature supports, daily dose of 100, 700 milligrams of up to 9% THC, and that's of dried cannabis extract. So this is a little bit dated, but with the various formulations and oils and capsules available out there, it really is much easier these days to find a dose that actually works best on a patient specifically instead of blinding them and kind of categorizing them on these generic recommendations that we have. So with respect to product selection, we've got multiple products out there. So there's oils and capsules. These are preferred usually for chronic conditions. Once you're going to be taking this as helpful for your condition, you want to make that switch over. Inhalation products work well for rapid onset of acute symptoms. So if someone's having an acute pain attack and needs rapid relief, topicals work well for localized pain and inflammation. And then edibles, they offer long-lasting effects for chronic pain and sleep disorders. And then what I don't have on here, but suppositories are also a real great route of administration, especially for our female patients. If there's endometriosis, a lot of the rectal and suppository routes, vaginal routes, can offer an alternate route of administration without the systemic side effects that some people tend to experience. So drug interactions. So just going back to pharmacology school and remembering, when we think of drug interactions, there's of two types. There's pharmacokinetic interactions and there are pharmacodynamic interactions. And so when we think about drug interactions with cannabis, kinetic interactions is the ADME. So absorption. Cannabis can affect the absorption of other drugs. For example, it can slow down the absorption of some medications taken orally. Distribution. Cannabis can alter the distribution of drugs in the body by affecting how they bind to proteins in the blood. And metabolism. So this is a big one. This is, where, if you're starting a new medication and you're unsure, check with your pharmacist. We have the tools, resources, the references to look up a medication or a drug or a plant interaction to see, what can we do to mitigate that risk. And that's because with respect to metabolism, cannabis can influence the metabolism of other drugs, particularly those metabolized by the liver's enzyme systems. So think CYP450 and then think back down to C3A4 and the CYP2C9 pathways. For instance, it can increase the levels of certain drugs like warfarin, leading to higher risks of bleeding. And then excretion, how cannabis leaves our body. And cannabis can affect the excretion of other drugs, potentially leading to higher or lower levels of drug in the body. So that's just some, kinetic interactions. And then there's pharmacodynamic interactions. So there could be additive effects where cannabis can enhance the effects of other central nervous system depressants like alcohol, benzodiazepines, and opioids, increasing the risk of sedation and respiratory depression. So there is an appreciation where we might be wanting to use cannabinoids to taper off as a harms reduction of these agents as well. So when that's happening, it's really important, if you're using the two agents together, to really be monitoring our patients. There's also antagonistic effects. So cannabis might counteract the effects of certain medications. For example, it can reduce the effectiveness of some antipsychotic medications. So, there's some interactions to bear in mind, and it's always important to double check. If you're not certain, there's resources out here. So here's just a little graphic that illustrates cannabis and your medication. So pretty much every therapeutic category of medications is on this list. But I would think specifically CNS depressants, antiretroviral drugs, some antibiotics, antifungals, the TCAs, the MOIs. If your patient's on any of those would be the red flags to double check to see what type of interaction it is and how you can mitigate that interaction. Sometimes it's a game of dosing at separate times. Sometimes it's a game of dose adjusting or reducing the level of one or increasing the other. So there are ways to work through the drug interactions. Having a drug interaction doesn't mean you can't take the two together. It just means, something might happen. How do we reduce that harm that may come of that? So when we're monitoring our patients, really we're monitoring for two things: efficacy and side effects. So how are you going to monitor that? Well, I think it's essential for caregivers and patients alike, and prescribers to encourage therapy logs. So have your patient monitor their outcome to it. Like, here, this is a sample therapy log, and what we're really wanting to look for is it helping with your symptomology? What's your pain level? What are we using for? Is it actually being effective for what the needs are? And then we want to look to see the side effects. Are you experiencing side effects by the use of this? What type of side effects? And so those are all questions to ask. Some of the major adverse events are listed here. So most of the major side effects usually are drowsiness and fatigue, and that's usually if it's a THC-based product, because it does cause sedation, dizziness, dry mouth, cough. And that's more if it's a combustible product. So we can mitigate cough if we encourage non-combustible products. Anxiety, nausea, cognitive effects. Again, these can all occur when you're starting the medication, but oftentimes patients can develop tolerance to the side effects without diminishing the pharmacological effectiveness of the medication. Here's just a little guideline for clinicians for what to do when they're going to follow up with a patient. So it's just a yes or no based on like, how are you tolerating the medication? Have you done this? Are you experienced this side effect? And to work through it. So if anybody wants a copy of it, Dr. Bid, you're welcome to share. And same with this little cheat sheet here is just what to do and what to watch for with patients taking medical cannabis. So if they're experiencing a side effect, then they can try this, and then other considerations. So, for the sake of time, I'll leave this up for you guys to have a look at, or Dr. Bick can share it. One thing that, I don't think we see it, but we should maybe be aware of, is cannabis-induced hyperemesis syndrome. So this really is a condition where someone that gets sick, starts throwing up, even though they've been using cannabis for some time. So it tends to happen in patients that have already been long-time users, and it's conservative management. There's no like, if you experience it or develop it, I don't think there's going to be a retrial of it, just because we don't know what's causing it. So oftentimes it's a condition that affects some long-term cannabis users. It's characterized by cycles of severe nausea, vomiting, and abdominal pain. And despite knowing that cannabis works well for chemo-induced nausea and vomiting, and it's well-known antiemetic properties, cannabis hypersyndrome, it presents as this paradoxical experience to cannabis, where chronic users experience these distressing symptoms. So just something to bear in mind, that this can happen. So symptoms include persistent nausea that often worsen in the morning, repeated vomiting and retching, which can occur up to 5 times an hour. So people could be dry retching and not feeling very great. Abdominal pain that is typically mild and diffuse, loss of appetite and weight loss, and then sometimes compulsive hot bathing or shower, which temporarily relieves symptoms. So if your patient's going in and showering, and why are they doing it? Maybe this is what they're experiencing. Management includes, cessation. So stop using cannabis is crucial. This is really the only way we know how to maintain it, or like treat it. Hydration. We want to ensure there's adequate fluids intake to prevent dehydration from the vomiting. Hot baths and showers. So taking hot baths or showers can provide some temporary relief from the symptoms. Sometimes a medical treatment may be needed in severe cases where hospitalization may be necessary to manage dehydration and electrolyte imbalances. And then medications like antiemetic to control nausea and pain, pain relievers may be prescribed. So really seek supportive care if it happens, and just be aware that it is a side effect to be mindful of. Withdrawal and dependence. So we'll just briefly touch base on this. Cannabis withdrawal is 3 or more of the following signs and symptoms developing within approximately 1 week after the cannabis cessation. So if one of your patients has been using it, and then they no longer have a need for it, and they find that they're irritable, or they're becoming more angry or aggression, nervousness or anxiety, sleep difficulties, decreased appetite, restlessness, depressed mood. So at least one of the following physical symptoms causing significant disorder, including abdominal pain, shakiness, tremor, sweating, fever, chills, or headache. So cannabis withdrawal pretty much is like any other pharmaceutical withdrawal, like an opiate withdrawal. You want to try to manage it the best you can. It's not like threatening, but it can be bothersome. So supportive management is necessary, and people should be aware that, especially if they've been using it for chronic use and hopefully the condition has resolved and they want to go off of it, that withdrawal is a potential, and we can mitigate that by, again, slow and steady titrations, supportive, and offering non-psychoactive cannabinoids such as CBD if you are tapering off a THC protocol. Cannabis use disorder. So this is when patients may be drug seeking and they may not have a need. This may imply more to THC psychoactive products. As we legalize more, throughout the different countries in the world, we're going to find variations of THC and how people view it based on, I think cultural influences, country influences, and just as we find more research and data that supports THC use. But a lot of cannabis use disorder tends to stem from the THC use because it's the euphoria, and people tend to want to abuse that because it makes them feel good, but it may not be beneficial. So mild is a repeated pattern of use and intoxication develops over an extended period of time and leads to harmful consequences such as recurrent failure to fulfill major roles, responsibilities, or persistent social problems. So it's that stoner couch potato stereotype that we try to want to avoid. That's where we might see the cannabis use disorder creeping in. And then moderate to severe is behavioral and physiological symptoms resulting from compulsive use that may continue despite ongoing physical or physiological problems caused by cannabis use. Features include using larger amounts of cannabis over longer periods of time, unsuccessful efforts to limit use, tolerance, and possible physiological withdrawal. So just some things to keep in mind. And then, at the end here, it's about counseling patients too. We want to make sure, prior to providing any dose recommendations, ensure patients have a valid medical authorization and no contraindications to use. So, 25 years and younger is one of the contraindications I would suggest for THC, just because the brain is still developing. Pregnancy, lactation, we still don't have enough data. And if patients have, liver failure, renal disease, we still don't have enough guidelines that help with dosing recommendations. So that's where we would really be cautious, monitor the patient, and look at real world evidence to help dictate how we can dose those patients. And then, like I mentioned earlier, certain psychiatric conditions, especially if there is a family history or patient history of schizophrenia, psychosis, bipolar, that mania, we really want to caution patients in utilizing THC-based products. And if they were to, start on cannabinoid therapy, it should be under the supervision of a medical professional that understands how to use these tools in those given conditions. Patients can use medical cannabis in conjunction with prescription medications. So check for drug interactions. That's what pharmacy is there for. Most patients can use anywhere from 1 to 3 grams of medical cannabis a day, but again, it's very patient centric. So go slow and titrate. And again, the primary approach of titration medical cannabis is start low, go slow, and stay low approach. So once you find a dose that alleviates the symptoms and there's good efficacy, then you're good. We can keep that patient at the dose. And if something changes, you can always go back and titrate again. But really, slow and steady will help the patient find the best dose that works for them. Patients quickly develop a tolerance to the psychoactive adverse effects of cannabis without losing its therapeutic benefits. So, if they're on a THC product and they don't feel the euphoria anymore or the high of it, it's a good thing because we want them to be using it as a medicine. We're not trying to get them high. We're trying to control whatever symptomology they're trying to target. And that's usually pain relief or nausea, etc. And if using cannabis with high THC concentrations, recommend using it at bedtime to minimize some of those adverse effects. CBD may offset the psychostimulant properties of THC. So again, and then it could help with CBD by working in synergy. So we can recommend strains with higher CBD content for daytime use. Reducing the dose or frequency of use if adverse effects persist and interferes with daily functioning. So again, if you've titrated up your patient starts to feel, sedated throughout the day, or not getting the same benefits, and they feel overly drowsy, dry mouth, etc., we can try backing off. Remind patients that the euphoric effects of cannabis are not required to attain symptom control. So patients that are using THC, you can remind them, sometimes we just need a little bit to help with the other cannabinoids, and that little can go a long way. And use of medical cannabis through smoking can be harmful and should be discouraged. Now that we have, so many product availability out there, there's a time and place for combustible products, but one should be relying more on the non-combustible formulations, just from a harm reduction point of view. Anytime you smoke up something or you combust something, it's still going to have partial harm to the lungs compared to when you don't combust a product. Um, Choose oil form for chronic conditions where long duration effect is desired. Choose vaporized cannabis for quicker onset of action for breakthrough or periodic symptom management. So that is the only time we'd really want to be using something that's vaporized or combustible. And provide and encourage the use of medical cannabis therapy logs. So if your clinic has a therapy log, great. If not, there's generic ones available online. I think it's very important for patients to take ownership of their care, monitor to see how the tool is working for you, what side effects you're experiencing, because that's the only way we can really tailor it back to their needs. All right, Dr. Bid, thank you. I've left some time for us to jump into Q&A now.
Thank you so much, Anita, for the great presentation. It's such a wonderful presentation, which includes a very simple but very important and critical information, which many people kind of like miss. And that's what I always kind of like talk with the various different dispensaries and patients, that like how to take and how to approach the medical cannabis when you are using it. What kind of different symptoms that you are expecting if you are a first time user. Low and slow is the it's the one of the important thing that like which everybody need to remember, as we discussed, that like as you mentioned, that it's a personalized therapy and everybody is different, everybody's genetics is different. So I think that like it is really important for everybody to know that like these cannabinoids have a wonderful um, uh, wonderful properties. And it's again, it's a simple thing that like more about any drug, including medical cannabis, the advantages and disadvantages, what role it play, and how to safely utilize this. I think that like we can very safely say that in today's world, based on the scientific literature, that it is really really important drug, and TSC is not a bad guy. I always tell people that TSC is not a bad guy. It's all about that because I argue all the time that like even though more than three glass of water is essential for life, is not good for the body, because body don't need more than that. So
Yeah.
for sure that like the whole aspect is really important. The information you shared is really critical. But along with that, I wanted to mention a little bit about that like the aspect of pharmacology, which is basically, as we mentioned, that medical cannabis is a personalized therapy, and everybody has the various different expression of endocannabinoid system. Based on that, there is a really big field which is coming, which is called basically that pharmacogenomics and
Yes.
pharmacogenetics, which is coming a really big playing a very big role. And with the time coming, then when it will be a mainstream medicine, then clinicians will be able to send the patients to understand about the expression profile and the secretion level of anandamide 2-AG and many more endocannabinoids in the body. And based on that, when they are going to treat the patient, I think that that will be more selective treatment. There will be
Hmm.
more chances of better outcome for the patients. I think that this is a really critical thing and really important kind of aspect that like I am very excited about, because like I think that pharmacogenomics of medical cannabis is one of the important area that which is coming really big, and it is going to make a big difference long term for the patient's treatment outcome. Along with that, when you mention about that drug interaction, that as we all learn about that like our body is really unique, and cytochrome P450 CYP enzymes are really critical to digest the various different drugs, right, and
Hmm.
metabolize the different drugs. So it is really important for the users to understand that, this drug-drug interaction is really critical, but not at that level, because, clinicians need to understand about the drug-drug interaction. But so far, the research, what we are talking about, various different drug research, is basically between the cannabinoids, and mostly focus on, so far, that the data we have is basically opioids. Either we talk
Mm-hmm.
about morphine, codeine, oxycodone, methadone, tramadol, fentanyl, acetaminophen, we talk valproic acid, etc. So basically, that, the data is based on the all the painkillers, etc. And opioid addiction is one of the biggest, kind of like, quote unquote, issue in United States, that where that after the more than 27 states are recreationally approved, that, current data is indicating us that, like, the opioid addiction is basically 65% reduced in those states, which is a really, really huge data. And when you
Mm-hmm.
talk about that, like, pharmacology of cannabis, and when we talk about the pharmacokinetics and dynamics, I need to tell the users to just to understand the picture, that how important that pharmacology is. Because end of the day, that so far we have 4 different medications which are approved from FDA, and one of the first medication, Epidiolex, which is basically a CBD distillate for Lennox-Gastaut syndrome and Dravet syndrome, and which is really, really critical to understand that, there are so many medications are there, but to get the approval from FDA, we need that data, because FDA need only 2 things, as you know, and you mentioned, that one is the safety profile, and another one is that how this drug is going to action in the body. That means mechanism of action, because that's really important, where it is going to bind, and or how it is going to, like, play a very important role. So that's, I think, that this is really important, and that's why that I think that pharmacist plays a very important role, like you, in the whole treatment, making the treatment schedule. Because I think that as a scientist, as a clinician, as a pharmacist, as a nurse practitioner, we all are facing the same challenge globally, that which is the consistency of the purity and potency of the product.
Yeah, and that's the thing. There's too much availability. There's no regulatory framework in place right now. So I think it's crucial for us as clinicians to say, hey, patients have access to this. So how do we mitigate risk? Come from the lens of harms reduction, right? And as a pharmacist, my job is to do no harm and to allow my patient to make informed, shared decision making. So if they're going to want to use cannabinoids, let's help them mitigate that risk, whether there be, identifiable drug-drug interactions or drug-disease interactions. Hold their hemp, titrate very slowly, figure out their sweet spot, their dose, and then you can open up other product selection. But, that's how we line it up to how we see traditional Western medicine. Right now, it's still very much a free for all. I'm sure even in the States, everybody wants to do it their way. And, I don't know what the right way is, but I think right way is to really collaborate, focus on patient centric dose titrations, and share the data. The more data we have to work off, real world evidence, the more better outcomes we'll see for patients.
I totally agree with you that, like, that collaboration is really important. And I think that, like, that's the real collaboration we are showing here, that bringing you from a different country to show your perspective, that, like, where and how the things are happening in Canada, and comparing that landscape with United States, is, I think, that it's a real world example that we are showing hands on to the listeners, that it is really important to show the data, because every country, that genetics, human genetics is different,
Hmm.
ethical plans are different, but also that I think that, like, the plant genetics also plays such an important role. And when we talk about the variability in the sense that how the plant even it's growing, because you cannot control the nature, and indoor, outdoor, and there are so many factors are there, that which plays
Hmm.
important role for the production of the cannabinoids. And then continuously it is going to affect, because the different kind of extraction methods, different kind of testing standardization, different
Hmm.
kind of approach to treat the patients makes such a big difference, that I think that, like, it is going to make a tremendous kind of like a success in this industry. One is that collaboration, but the another thing that which I was about to ask you, because, like, because I've been in education educating cannabis, either it is policymakers, or either MDs, or either nurse practitioners, creating various different CMEs courses, and along with that the consumers also. And I feel like that's various different educational partners as well as the educational institute that to treat and to teach the people, and the people who are taking the responsibility to treat the patients, is really important to educate them that what's going on. And one of the most important thing is this is a fast growing industry. Things are changing, the landscape is changing so
Yeah.
fast that as an educator or as a clinician, that you have to update yourself also, that what is going on in this field. And currently,
Right.
that like if you think about that, we just touched the tip of the iceberg. We just talk about, and we hear from your lecture. And my question was to you, because I work as a consultant for a company that where they were specifically focused on acidic cannabinoid. We talk
Mhm.
about acidic cannabinoids, we talk about neutral cannabinoid, we talk about verenic cannabinoid. And then after that, there are more than 120 or 200 different cannabinoids are existing in the plant. But so far we have a data of maybe like less than 10, but majority of data is CBD and THC. So
Right.
how you see that that landscape is going to change, and how far. But before even answer that question, there was a question from Cannabis with Liz Education, that the question is, did the FDA state that cannabis can in fact be useful as medicine this year?
I don't know your American laws because it's state by state, but you guys are up for election, and I know they've been asking for
Yes.
stakeholder
So
feedback,
so
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 push
so
for it.
to yeah. So to answer this question, that I think that FDA is always support of medical cannabis. The only problem is that because FDA need to keep up with the rules and regulations and policies, and I think that is really important, because it's FDA's job that whatever is going to in our body on consume or utilize, that it need to be screened for safety and mechanism. And that's the kind of like a real challenge, because if we know the mechanistic part, that pharmacodynamics part of the CBD itself has a more than 46 target in the body. But in
And that's why
spite
I'm
of
like, it's
that,
not specific to CB1 or CB2 receptor, but we know it's working. And as soon as you start working on the pathway of where it starts to work on, and the down cascade effect, unless you have a pharmacology background, the average, clinician, it's over and above us, right?
yeah,
We just
yeah,
want to know, like, lock and key effect, where is it binding, what's its response? But because of the entourage effect and the affinity for different receptors, it's so different from traditional pharmacology and Western
yeah,
science.
yeah,
And that's where, like, we have to rely on real world evidence. Like, this was a medicine, this was a tool before pharmacy and pharmacology took place in the early 1900s. But before then, we were using it as a tool, as a medicine. Traditional medicines are, you and I both come from ancestry in India, so Ayurvedic medicine, cannabinoid medicine, it's there. It's now we need to catch up with real world evidence. We can't look at this the way we have traditional pharmaceutics, because it's not a single API molecule. So we're going to have to develop methodologies and how we can actually see this working and what its effects and side effects are. And that's why real world evidence, AI, collaboration, and the more data points we get, the more we'll learn. And it's going to come, not just from like one angle, it's going to come from everybody.
and that's why that the when we were talking about the FDA, that's a big example that FDA is acceptability is there, because as I mentioned, in spite of having more than 46 target of CBD, FDA approved that CBD distillate, which is Epidiolex, for two different kind of unique epileptic diseases, Lennox gastaut syndrome and Dravet syndrome.
And these are pediatric conditions. So
And
what
this
we're
is
finding in
pediatric.
adults,
Yeah, yeah,
but in adult seizure conditions, we're not having that same sort of response.
yes,
And we
yes,
know we're needing THC. So we know here we beg to differ. Entourage effect,
yes.
where is the two working together in synergy? What's happening? Because it's comparing apples to oranges. They may be fruits, but they're going to work differently.
And pediatric, that it is really complexity, because it's a growing body,
Yes.
it's a growing cells, everything is different. So that's a big example. So definitely, to answer to Liz's question, that FDA is accepting this, but we need to standardize our system, we need to standardize our testing system, the whole system, to create so that we can provide more kind of like evidence to FDA. And one of the biggest advantage, I think, that Anita, that like for the clinicians and the people that who are working and using medical cannabis is that because I'm coming from a scientific background where my whole life was looking for the discovery of the various different molecules, small molecules, peptides, and big molecules, monoclonal antibodies, etc. And when we start from the zero, from the laboratory petri dishes, and then when it reaches to the human body, it takes like 20 to 30 years. But the beauty in medical cannabis is that we are allowed to use and collect the substantial and objective data from the dispensary hands-on, and which can support our new applications for FDA, that hey, we use this formulation in humans, and we are cutting basically 10 to 15 years of our hardcore research on the preclinical studies, etc., because we are treating humans with safely and we are getting the response from them, which is a really, really big win, which people need to understand that how important it is that for us, and how big advantage we have in this field of medical cannabis to create a big data set, to create a good clinical trials, so that like more and more drugs will be approved, and to create a standardized system to the whole process. And I think that this whole process can only be happen because of the power of the education that what we are doing right now here. Either we are educating the customers, either we are educating the patients, either we are educating the clinicians, nurse practitioners, pharmacists, etc. I think education is the power, which is the most important thing to give us the update and utilize that how important it is, and to make them everybody understand that how much data set, how much scientific discoveries and reports are already there, which prove again and again and again that how wonderful this drug is. So thank
Yeah,
you so
no,
much for
definitely. No, my
yeah.
pleasure. And like even with like we got a glimpse of it like when we were working over with the India project, we were seeing good response in cancer. So that's why I'm like
Yes.
there's so much real world
Yes.
evidence to
Yeah.
connect. I kind of stuck to what I knew from the Health Canada standards, but like we've really just the tip of the iceberg, and it's really going to take dialogue like this where everybody come together and let's promote this, because it's a wellness tool, it's a health tool, and most importantly, it's allowing for patient-centered care. We can really cater to the patient's needs utilizing
For
this.
sure, for sure. Thank you so much. It's always a pleasure, and it's always a
Yes.
great time with you to discuss the this plant and the medical benefit and the pharmacology, etc. And thank you for always accepting the invite and sharing the great knowledge with our listeners. So thank you so much for today's presentation, and thanks for all the listeners that who are listening. And be tuned and be ready for the third GMCS Masterclass, that where we are going to talk about the medical cannabis and anxiety disorders. And we are going to continue this mission to educate the clinicians, to educate the medical fraternity, to educate the patients, and give the plant the respect that what it needed. And I think that education is the power that which will give a lot of success to the plant, and we can utilize this plant for the patient's benefits. So, Anita, thank you so much again, and have a good night, everyone.
You too. Thank you.
GMCS Masterclass, Medical Cannabis Essentials, produced by the Georgia Medical Cannabis Society, brought to you by our dedicated volunteers and generous donors. Special thanks to Anita Rasoda for sharing her expertise. Support our cause to keep programs like this going. Donate today at georgiamcs.org. The Georgia Medical Cannabis Society is a 501(c) nonprofit, and all donations are tax deductible.